Hello, I'm Dr. Craig Hirsch, an associate physician in the Channing Division of Network Medicine and the Division of Pulmonary and Critical Care Medicine at Brigham and Women's Hospital, and an associate professor of medicine at Harvard Medical School. This lecture will be on COPD, pathobiology, and assessment. These are my disclosures. The outline of today's talk. First, we'll talk about the definition of COPD and risk factors for COPD. Then discuss pathophysiology and biologic mechanisms. Next, we'll move on to the assessment of COPD patients and conclude with the board review questions. This is the definition of COPD from the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, as seen in the URL below. And this is an excellent source for information about COPD that is updated every couple of years, and the last update was just this past year. According to GOLD, COPD is a common, preventable, and treatable disease characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities, usually caused by significant exposures to noxious particles or gases. And we'll go into more detail about the parts of this definition. This slide shows the risk factors for COPD. Traditionally, we think of COPD risk factors as being inhaled, mainly cigarette smoke in the developed world. Other exposures that may be important for COPD include occupational exposures to dust and chemicals, environmental tobacco smoke exposure, and indoor and outdoor air pollution. More recently, we're learning that genes are an important risk factor for COPD. Infections can lead to accelerated decline in lung function. And socioeconomic status is increasingly important as COPD is becoming more prevalent in people with lower socioeconomic status in the Western world. And overall, COPD is increasing due to the aging of the population. On to the pathophysiology of COPD. This slide shows changes in the lung parenchyma in COPD patients, emphasized in this electron micrograph here. In the cartoon, we see that emphysema is characterized by destruction of the alveolar walls, leading to loss of elasticity, with a concomitant destruction of the pulmonary capillary bed. The inflammatory cells in the lung parenchyma are macrophages and CD8 positive lymphocytes. And here's a histology slide showing the same changes on the previous cartoon. Here's a normal lung with the fine alveolar attachments surrounding this normal airway. Whereas in the COPD lung, we see a loss of the alveolar attachments, which is known as emphysema, leading to collapse of that conducting airway. This slide shows the changes in the large airways of COPD patients. In the airway lumen, there's hypersecretion of mucus and neutrophils, which can be seen in the sputum. There's squamous metaplasia of the epithelium, but no thickening of the basement membrane. In the interstitial side, we see increase in macrophages, CD8 positive lymphocytes, with little increase in airway smooth muscle. COPD is also characterized by goblet cell and mucus gland hyperplasia, leading to the mucus hypersecretion. And here is a histology slide showing those changes. In this slide, mucin is stained in red, marked with this M here, which shows a large globule of mucus in the airways, and at higher power, you see the mucin in each cell being ready to be secreted into the airway here. This slide shows the changes in the small airways of COPD patients. There's an inflammatory exudate in the airway lumen and thickened alveolar airway walls with inflammatory cells, macrophages, CD8 positive cells, and fibroblasts, leading to parabronchial fibrosis. We see again the disrupted alveolar attachments that we saw from emphysema, and here is a lymphoid follicle which can be seen in advanced COPD. And again, here is the histology slide, and again to remind what a normal small airway looks like. And here we see a greatly thickened epithelial layer with not much smooth muscle hypertrophy, which is more characteristic of asthma. So how do these changes lead to airflow limitation? Normally, the airway is held open by the elastin fibers, the alveolar attachments shown by these arrows. In COPD, the emphysema causes disruption of the alveolar attachments, and the changes in the airway, namely the mucosal inflammation and fibrosis, and the mucus hypersecretion are seen in this cartoon. So the airway becomes obstructed by those three processes: collapse from loss of alveolar attachments, and then the luminal changes of both inflammation, fibrosis, and the mucus exudate. So how do these lead to symptoms? The emphysema and small airway obstruction lead to lung hyperinflation and air trapping, which causes dyspnea, especially with exercise, reducing the patient's exercise tolerance, which leads to deconditioning in a vicious cycle. Mucus hypersecretion leads to symptoms of cough and sputum, and both the decreased exercise tolerance, the cough and sputum, and deconditioning all lead to poor health status and symptoms in the patient. Now we'll move on to pathobiology mechanisms of how tobacco smoke causes COPD. The traditional model of COPD is a balance between proteases and antiproteases in the lung. The most classic antiprotease is alpha-1 antitrypsin, and the proteases other proteases we talk about are neutrophil elastase, cathepsins, and macrophage metalloproteins. In the normal lung, these are balanced, but these become imbalanced in COPD and lead to excess lung destruction. As I mentioned, alpha-1 antitrypsin deficiency as a disease is a model of this protease-antiprotease imbalance, but proteases and their inhibitors are important in COPD, not due to alpha-1 antitrypsin deficiency. So we know that cigarette smoke and inflammatory cells are both important causes of oxidative stress, leading to oxygen-free radicals, shown here, which affect that protease-antiprotease balance, mainly by decreasing the antiprotease function, such as SLPI, or secretory leukophosphate inhibitor, and alpha-1 antitrypsin, and leading to increased proteolysis. These free radicals lead to mucus hypersecretion, bronchoconstriction, and plasma leak, and are thought to be involved in steroid resistance. Cytokines such as CXCL8 and TNF-alpha are involved in recruitment of neutrophils into the airways, which perpetuates this cycle. So in the airway itself, the cigarette smoke leads to secretion of growth factors such as TGF-beta, which leads to the remodeling of the airways, namely the peribronchial fibrosis and the mucous metaplasia, with minimal amounts of smooth muscle hypertrophy, leading to thickening of the epithelium, which leads to airflow obstruction. As well, the cigarette smoke activates the macrophages to secrete various factors such as IL-8, which recruits neutrophils, and CXCR3, which recruits CD8 lymphocytes. And these, as well as the macrophages, release proteases, which lead to elastic fiber damage and emphysema, and both these processes together, the emphysema and the airway remodeling, lead to the airflow obstruction that is diagnostic of COPD. Although the protease antiprotease hypotheses and the inflammatory hypotheses are both useful models of COPD, there are some limitations to these ideas. First of all, it takes many years for COPD to develop, often decades after the initiation of smoking. And we know that the inflammation persists even after smoking cessation, and lung function may continue to decline after smoking cessation. And if COPD was purely an inflammatory disease, we would expect a good response to corticosteroids, both oral and inhaled corticosteroids, but in general we see a minimal to poor response to corticosteroids, except in the setting of acute exacerbations of COPD. So why is there persistent inflammation in COPD, especially after smoking cessation? One theory has to do with these lymphoid follicles, which are seen here in the small airways in patients with severe COPD. These are stain positive for both B cells and CD4 positive T cells, which may perpetuate the inflammation even years or decades after smoking cessation. Other mechanisms are likely important in COPD, including cell death or apoptosis of the alveolar cells, leading to destruction of the alveolar membranes and alveolar wall, leading to emphysema. As mentioned before, COPD is a disease of aging, and there are biological processes related to aging which are important in COPD, including cellular senescence, DNA damage, and inaccurate or impaired DNA repair. We know that telomere shortening may be important in COPD, and overall there are fewer stem cells for the maintenance of the alveoli in COPD. I mentioned before the importance of the adaptive immune system and the lymphoid follicles, as well as the potential for autoimmunity perpetuating COPD. So this leads to a revision of our model of COPD, explaining the decades from the first cigarette to emphysema. Oxidative stress is still the unifying theme, leading to the disruption of alveolar maintenance by the mechanisms we discussed earlier, mainly the inflammation and the protease-antiprotease imbalance, but also recognizing the importance of apoptosis or cell death, and the other newer mechanisms such as aging, autoimmunity, and all of these lead to an amplification loop which continues this process even after smoking cessation. Traditionally, COPD has been thought of as rapid decline in lung function, but we know that's not necessarily the case. This is data from a recent paper in the New England Journal of Medicine showing growth and decline of lung function. So in the normal setting, lung function continues to improve or continues to grow with the growth of the body and plateaus around age 20 to 30 and then begins to decline in this green line. So this is a normal rate of decline with aging. This red line represents the traditional model of COPD with normal lung growth, normal lung plateau in lung function, and accelerated decline, presumed due to cigarette smoking. And that is one pathway that leads to COPD. Alternatively, we know that patients can have reduced lung function growth, so reduced maximally attained FEV1, shown in this other dotted line here. And that may be due to childhood abnormalities in childhood lung development, early life infections, or asthma, leading to reduced lung growth, and then the normal rate of decline, shown in black, leads to COPD. There are some patients who do have small lungs but have a slower rate of decline, shown in the orange, which does not lead to COPD. So we know two pathways can lead to COPD: accelerated lung function decline or reduced lung function growth. So moving on to the assessment of COPD patients. So according to Gold, there are four things we need to assess when we assess a COPD patient. First is assessment of the symptoms, assessing the degree of airflow limitation using spirometry, assessing the risk of exacerbations, and assessing comorbidities. So this slide shows the signs and symptoms of COPD. The symptoms of COPD are fairly nonspecific, including common pulmonary symptoms such as cough, sputum, dyspnea, wheezing, and chest tightness. It's notable that symptoms such as wheezing and chest tightness cannot be reliably used to differentiate COPD from asthma. In more severe cases, patients may notice weight loss, muscle weakness, peripheral edema, and depression, which is an important comorbidity in COPD. Again, the physical exam is not very useful except in the most severe cases. At that point, patients may sit forward in the tripod posture to improve their breathing. Patients with low blood oxygen may have cyanosis of their skin. When observing the patient breathing, they may have tachypnea or a rapid respiratory rate. They may have pursed lip breathing, a prolonged expiratory phase, and in the most severe cases, accessory muscle usage. Lung hyperinflation may lead to a barrel chest, which could be evident on exam. On auscultation, breath sounds are distant and wheezes may be heard. As well, the cardiac sounds may be distant. An increased second pulmonic sound may be indicative of pulmonary hypertension, along with jugular venous distension and edema. And in the most severe cases, we may see cachexia or peripheral muscle wasting. To systematically assess the symptoms of COPD, we can use tools such as the COPD assessment test or the CAT test, which is an 8-question test scored by the patient on a 0 to 5 scale, encompassing common symptoms such as cough, phlegm, chest tightness, exertional dyspnea, activity limitation, sleep, and energy, as well as a global assessment of how confident they are to leave their home. The scores are added up in a simple point system, and 10 points or more is considered to be symptomatic COPD. The modified MRC dyspnea scale is a shorter assessment that can be used in the exam room with the patient. It consists of 4 questions assessing their dyspnea graded on a scale from 0 to 4, with normal being only getting breathless with strenuous exercise, to the most severe of being too breathless to leave the house or breathless when dressing. Consider a score of 2 or more to be symptomatic COPD, corresponding to patients who walk slower than people of their same age or have to stop breathing when walking at their own pace. The next step in a COPD assessment is assessing the severity of airflow limitation. This slide shows the GOLD spirometry stages based on post-bronchodilator FEV1. GOLD defines COPD based on an FEV1 to FVC ratio less than 0.7. Once that criteria is met, the severity of COPD is graded based on the FEV1, using the cutoffs shown in this slide, leading from mild COPD to very severe COPD with an FEV1 less than 30% of predicted. Assessment of exacerbation risk is rather simple in the office, since we know that previous exacerbations are the best predictor of future exacerbations. This slide shows data from the observational ECLIPSE study, which followed COPD patients for 3 years. At the initial visit, patients were asked how many exacerbations they had in the previous year, and those with no exacerbations are shown in this yellow color, and they were most likely to have no exacerbations in the second year and no exacerbations in the third year. Conversely, patients with 2 or more exacerbations in the first year, shown in red, were most likely to have 2 or more exacerbations in the second year and 2 or more exacerbations in the third year, showing the stability of this frequent exacerbator type. So these different pieces of assessment are combined in this new GOLD recommendations from 2017. We use spirometry to confirm the diagnosis based on a post-bronchodilator FEV1 to FVC ratio less than 0.7. Then the degree of airflow limitation is graded based on the FEV1, leading to these 1 to 4 numbers, with 1 being normal FEV1, all the way to the most severe. And then the symptoms and exacerbation risk are put together into this bidimensional assessment, with the highest risk patients for exacerbations, like we mentioned, having 2 or more exacerbations in the previous year, or 1 exacerbation leading to admission to the hospital, and lower risk patients having 0 or 1 exacerbations without a hospital admission. And then symptoms can be defined either based on the MMRC or the CAT score, with the threshold of MRC being 2 or more and the threshold of CAT being 10 or more to define symptoms. So we put these together. For example, a patient with GOLD stage A has few symptoms and low risk for exacerbation, while conversely a D patient has the highest risk for exacerbations and the most symptoms. In future talks, you will hear about treatment decisions which can be guided by this GOLD combined assessment. COPD has a differential diagnosis. Like any disease in medicine, most commonly the differential diagnosis for COPD includes asthma. We expect asthma to have an earlier onset, usually in childhood, and patients frequently have a history of atopy, such as hay fever, allergies, or eczema. Congestive heart failure is another cause of dyspnea in elderly patients, which would be expected to have crackles on lung auscultation and peripheral edema on examination, as well as restricted PFTs, not obstructed PFTs. Bronchiectasis patients may have obstruction on their PFTs, but would have symptoms of chronic cough and phlegm production, as well as abnormal airways seen on chest X-ray and particularly on chest CT scan. In developing countries, tuberculosis is an important differential diagnosis for COPD. We expect to see characteristic changes on the chest X-ray. Some rarer conditions which may mimic COPD include obliterative bronchiolitis, which is a disease that may be found in young non-smokers. There's occupational associations with this disease, as well as associations with collagen vascular disease. An expiratory chest CT scan would show air trapping characteristic of this finding. Diffuse panbronchiolitis is rare in the United States, but is seen in East Asia. It's more common in men and in non-smokers and may be associated with sinusitis. Imaging shows central lobular nodules on chest CT scan. After confirmation of COPD with spirometry, there are other tests we can use to assess a COPD patient. Frequently, patients undergo testing of lung volumes and diffusing capacity. The lung volumes help diagnose the hyperinflation, which is one of the pathophysiologic mechanisms in COPD. Measurement of arterial blood gases is recommended in patients with severe COPD. We know that oxygen saturation correlates well with the partial pressure of oxygen on blood gas, but gives no information about the partial pressure of carbon dioxide or CO2 retention on blood gas. A 6-minute walk test is an easy assessment that can be done in the office or the pulmonary function laboratory, which is used to evaluate for disability, as well as a mechanism for assessment before and after pulmonary rehab. Composite scores, such as the Bode index, have been proposed to give a multidimensional assessment of these different COPD aspects. The Bode score consists of the body mass index, the airflow obstruction measured by FEV1, the dyspnea score by the MMRC scale, and a 6-minute walk test to assess exercise capacity. And these are put together into a score which is a predictor of prognosis. Chest x-rays are often performed in patients with COPD. It may be actually better to examine for alternative diagnoses such as heart failure or bronchiectasis. Chest x-ray is fairly nonspecific in COPD, except in the most severe cases shown in this image, which shows flattened diaphragms, reduced lung markings, the narrow cardiac silhouette, and the reduced muscle mass or cachexia. A lateral chest x-ray may also show a barrel chest or hyperinflation. Chest CT scans, though not routinely ordered to assess COPD, may be more useful to determine the pathophysiological processes in a particular patient. These slides are representative chest CT images from 2 patients with severe COPD at a young age. This patient with a severely reduced FEV1 has severe destructive emphysema. The other patient has even more severe airflow obstruction with an FEV1 of 20% predicted, with no emphysema seen at all in a chest CT scan. There are small central lobular nodules consistent with airway disease being the predominant mechanism in this patient. Screening for alpha-1 antitrypsin deficiency is recommended in COPD based on the ATS-ERS guidelines in 2003, and there was an updated alpha-1 guideline published in the Journal of COPD within the past couple of years. The guidelines recommend screening in all symptomatic adults with COPD, emphysema, or asthma with irreversible airflow obstruction. GOLD takes a more measured approach, recommending screening for alpha-1 antitrypsin deficiency in patients with COPD at a young age or a family history of COPD. Just a brief review of alpha-1 antitrypsin deficiency. It's caused by mutations in the SERPINA1 gene on the 14th human chromosome. As mentioned before, alpha-1 antitrypsin is the major inhibitor of neutrophil elastase in the body. Alpha-1 antitrypsin deficiency follows an autosomal recessive inheritance pattern for the lung disease. The patients with severe deficiency, known as PiZ, have approximately 15% of the normal plasma levels of alpha-1 antitrypsin. Patients who with the PiZ type, so one Z allele, one S allele, so 2 abnormal alleles called compound heterozygotes, are also at risk for COPD. Alpha-1 antitrypsin deficiency is a rare cause of COPD and may account for 1 to 2% of COPD in the United States. Alpha-1 antitrypsin deficiency may present as usual COPD, but may have other clinical presentations as well. Classically, it is associated with emphysema at an early onset, for example, at age less than 45, maybe in patients without a history of smoking. The emphysema is characteristically described as a basilar predominance, and patients have a family history of COPD or emphysema. Alpha-1 antitrypsin deficiency is also associated with bronchiectasis when no other etiology is found. Alpha-1 antitrypsin deficiency could lead to liver disease and cirrhosis, especially in patients with family history. Other manifestations include necrotizing paniculitis and antiprotease 3 positive vasculitis, or C-ANCA positive vasculitis. There are a series of diagnostic tests for alpha-1 antitrypsin deficiency. Initially, this was discovered based on serum protein electrophoresis by the absence of the alpha-1 peak, but that's not a recommended test clinically in current days. Measurement of serum alpha-1 antitrypsin level is the most common screening test and can be performed in many hospital or commercial laboratories. To determine the alpha-1 antitrypsin, or PI phenotype, can be done with isoelectric focusing of serum, which is a confirmatory test based on low levels and requires a lab with specific expertise. We can also perform genotyping for the alpha-1 antitrypsin gene for the two abnormal alleles, the Z or the S alleles, in a patient with suspected alpha-1 antitrypsin deficiency. In patients with a known family history of alpha-1, phenotyping or genotyping is recommended as the first test. We know that COPD is a systematic disease, and we should be screening for comorbidities. Besides lung comorbidities such as lung cancer, pulmonary hypertension, COPD can be associated with multi-system comorbidities, including depression, cardiovascular disease, anemia, diabetes and the metabolic syndrome, cachexia and muscle wasting, osteoporosis, and peptic ulcer disease. Assessment of comorbidities is an important part of the assessment of a COPD patient. The initial screening for pulmonary hypertension is an echocardiogram, which should be performed if patients have clinical evidence or suspicion of right heart failure. The echocardiogram may not be ideal in patients with severe hyperinflation, and those patients may require right heart catheterization if there's significant concern for pulmonary hypertension. Coronary artery disease is common in COPD patients based on both the shared risk factor of cigarette smoking and age, as well as other mechanisms, and physicians should have a low threshold for evaluation of coronary artery disease, especially in patients with rapidly progressive symptoms, including dyspnea and chest pain. Lung cancer is another comorbidity in COPD, and we know from the National Lung Screening Trial that screening with chest CT scans may reduce mortality in lung cancer. Comorbidities such as osteoporosis, depression, gastroesophageal reflux, and anemia should be tested with the usual clinical assessments performed in patients this age. So to summarize this lecture, we reviewed the pathophysiology of COPD, including emphysema and large and small airway disease. We discussed mechanisms how tobacco smoke can cause COPD, the protease-antiprotease hypothesis, the importance of inflammation, including inflammatory cells such as macrophages, neutrophils, and T cells, how oxidative stress is important to both of the processes above, as well as newer concepts such as apoptosis, aging, autoimmunity, and abnormalities in lung development. We discussed the assessment of COPD, including symptom scores such as the CAT test or the MMRC, the risk of exacerbations by inquiring about previous exacerbations, the importance of spirometry in diagnosing COPD and grading its severity, and then testing for alpha-1 antitrypsin deficiency. We also discussed the evaluation of comorbidities and the importance of chest CT scans for lung cancer screening, and perhaps in the future to determine specific pathophysiologic processes in COPD patients. On to the board review questions. Which of the following is true regarding the Global Initiative for Obstructive Lung Disease, or GOLD guidelines? A. Either pre- or post-bronchodilator spirometry may be used for assessing COPD severity. B. A fixed ratio of FEV1 to FVC less than 0.7 may lead to an overdiagnosis of COPD in the elderly. C. A fixed ratio of FEV1 to FVC ratio less than 0.7 may lead to an overdiagnosis of COPD in young people. D. A patient with FEV1 of 95% predicted an FEV1 over FVC ratio of 0.68 does not have airflow obstruction. The correct answer is B. A fixed ratio of FEV1 to FVC less than 0.7 may lead to an overdiagnosis of COPD in the elderly. The reasons why answer A is wrong is that gold staging relies on post-bronchodilator spirometry. B is correct because we know that the FEV1 to FVC ratio declines with normal aging, so using a fixed ratio may overdiagnose COPD in the elderly. Conversely, a fixed ratio may underdiagnose COPD in younger people, is why C is incorrect. D is incorrect because we know that post-bronchodilator FEV1 FVC ratio less than 0.7 does define airflow obstruction consistent with COPD, and this patient would be categorized as having mild or gold stage 1 COPD since their ratio is reduced but their FEV1 is over 80% of predicted. Question 2. A 60-year-old male former smoker with a history of hypertension, gastroesophageal reflux disease, and allergic rhinitis presents with 2 to 3 years of progressive dyspnea and dry cough. His FEV1 is 60% of predicted. The FEV1 FVC ratio is 0.7. Chest X-ray is normal. The differential diagnosis includes A, COPD, B, diffuse bronchiectasis, C, asthma, D, all of the above, or E, A and C only. And the correct answer is E, A and C only. A is correct because we know that airflow obstruction, defined by a reduced FEV1 FVC ratio in a former smoker, is consistent with the diagnosis of COPD. B is incorrect because we would expect a productive cough, not a dry cough, in a patient with diffuse bronchiectasis, as well as abnormalities on a chest X-ray. C, asthma is possible in a patient with airflow obstruction with a history of atopy, specifically allergic rhinitis. Question 3. Which of the following is true regarding alpha-1 antitrypsin deficiency? A, all patients with alpha-1 antitrypsin deficiency have COPD. B, serum protein electrophoresis, or SPEP, is an effective screening test for alpha-1 antitrypsin deficiency. C, augmentation therapy is indicated in a patient with PI type MZ, a carrier, and moderate airflow obstruction. Or D, assessment of liver function is recommended in all patients with alpha-1 antitrypsin deficiency. And the correct answer is D, assessment of liver function is recommended in all patients with alpha-1 antitrypsin deficiency. A is incorrect because not all patients with alpha-1 antitrypsin deficiency have COPD. We know that smoking is a major risk factor for COPD in these patients. B is incorrect. As we discussed before, serum protein electrophoresis is not an effective test for alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin levels are usually the initial screening test. Confirmatory tests include isoelectric focusing of serum or DNA genotyping. C is incorrect because augmentation therapy is not indicated in PIMZ carriers. In these patients, the alpha-1 antitrypsin levels are above the protective threshold, defined as 11 micromolar or 50 milligrams per deciliter. Assessment of liver function is recommended in all patients with alpha-1 antitrypsin deficiency, since, as we discussed before, clinical manifestations include emphysema, liver disease and cirrhosis, paniculitis, or vasculitis. This concludes the presentation.